I know we're going to have this huge influx of people over the next 10 minutes because it's UCSF time, but I wanted to get going because we have a wonderful distinguished speaker this morning for the Evelyn Lee Visiting Scholar Lecture, and I want to make sure that we give her plenty of time. So I'm going to just make some comments about the lecture itself. This is a named lecture, and I think it's really important to have a sense of history and continuity and talk about why we have this lecture and its purpose, and then I'm going to hand it off to Dr. Mangurian to introduce our outstanding speaker today. So welcome to the annual Evelyn Lee Visiting Scholar Lecture. This is in Cultural Competency and Diversity, and it's sponsored both by the UCSF Department of Psychiatry Diversity Committee as well as the UCSF Office of Diversity and Outreach. And it's in remembrance of Evelyn Lee, who served as a clinical faculty member here for more than 20 years before she passed away in 2003. And the lectureship aims to further her mission of expanding diversity, equity, and inclusion in the field of mental health by bringing prominent experts to share their experiences and expertise with campus trainees, faculty, and staff. And I hope all of you will be able to take advantage today of the fact that we not only get a lecture, but that Dr. Choo will remain with us throughout the day and have an opportunity to speak with multiple constituencies. So just briefly, Dr. Lee was born in Macau, China, received her BA in social work from Chinese University in Hong Kong, and then went on to earn a Master's of Science in Social Administration from Case Western, and finally a doctorate in Mental Health Administration from the University of Massachusetts. She joined us in San Francisco in the early 80s, where she joined the Asian Focus Unit at SFG, now ZSFG, as program director, as well as being appointed an assistant clinical professor. She founded the first ever Chinese Family Alliance of Mentally Ill and helped organize the NICOS Chinese Health Coalition, which was and is a collaboration among 5 of the largest service providers in Chinatown with a mission of advancing the health of the Chinese community through advocacy, research, training, coalition building, and program implementation. Dr. Lee is clinical professor at UCSF, served as a consultant on cultural competence and diversity to many community health and mental health organizations, schools, hospitals, and at the local and state and federal level. She wrote and taught on a very broad range of topics, including cross-cultural communication, including the use of interpreters, refugee trauma, immigrant acculturation, intergenerational conflict resolution, the role of religion, and complementary, alternative, and integrative medicine approaches. We certainly could use her on faculty now. She's someone who was truly a trailblazer in areas of great interest currently to us and I think everyone at UCSF. In '88, she authored what was a very widely used parenting teen handbook called 10 Principles for Raising Chinese American Teens, which was subsequently translated into multiple languages, including Chinese and Vietnamese. Overall, she was a tremendously well-respected clinician, administrator, teacher, author, community advocate, and humanitarian. And this lecture both honors her and endeavors to keep the focus that she had throughout her career at the core of what we think about in the department and the university. I want to thank Christina Mangurian, our Vice Chair for Diversity, who brings her considerable energy to every aspect of the job, including taking the lead on this lectureship. I'm also extraordinarily grateful to the entire Diversity Committee and to Peter Uresti and Kiati Brumbaugh in particular for their work in helping to select our lecturer today. I also have to thank Renee Navarro, Vice Chancellor for Diversity and Outreach, and the Office of Diversity and Outreach, not only for their continuing ongoing support, but also particularly for their co-sponsorship of today's lecture. So I'd like to now turn it over to Christina to introduce our distinguished speaker today. I wrote it myself.
Thank you so much, Matt, and welcome everyone, and also welcome those of you online. I know there's a live stream viewing party at Mission Bay right now to watch the incredible Dr. Esther Choo. Dr. Choo is an associate professor in the Center for Policy and Research in Emergency Medicine at OHSU. She's a practicing physician and an NIH-funded scientist with expertise in drug policy as well as gender disparities in healthcare. She's the founder and strategic lead of Time's Up Healthcare, which is an initiative of the Time's Up Foundation, which advocates for safety and equity in the healthcare workforce. And her work in gender equity has been published broadly, including in journals like the New England Journal, Lancet, BMJ, and the Harvard Business Review. And she's actually editor of a new column in Lancet that focuses on equities in healthcare. Do you hear that beeping? Not sure what that is. Anyway, okay, somebody will help me with that beeping. Dr. Choo is one of those incredible and unique individuals who's able to, actually, why don't we try dealing with this? Sir, do you know what that beeping is?
I can contact facilities, but...
Maybe Nicholas knows.
This is an experiment in concentration.
I know. It sounds like it's coming, but maybe people can check their bags and see if they have something.
We'll keep investigating.
Okay, that'd be great. That'd be great. What's incredible about Dr. Choo is, in my opinion, is that she's able to synthesize, thank you, incredibly complex and data about really difficult topics like inequities in healthcare, and make them accessible to everybody and understandable, and make us think about opportunities to change and how to really promote equity in our workforce here. So I know we're going to all learn a lot, and I'm so pleased that you're here, and please join me in welcoming Dr. Choo.
Good morning. It really is an honor to be here and to be delivering the lecture in honor of Evelyn Lee. I do have a few conflicts of interest. They don't directly affect patient care, but I wanted to be clear about them. I also have a few caveats before I launch into my lecture. One is that I do focus on gender, and gender as a simplified binary variable only for the most part. That focus, which is in the interest of time, simplicity, and a dependence on existing data, is a vast oversimplification and neglects intersectional experiences. The objectives of my talk are these. We'll talk about the interconnected problems of gender inequity and harassment in healthcare. We'll identify challenges to addressing these problems, and we'll discuss potential approaches to these problems over the next 45 minutes or so. I did share with Dr. Mangorian how much I struggled with this lecture, although I have given similar lectures many times, and that is because having spent many hours looking at the work that UCSF is doing, I think you have incredible institutional strengths. And I do realize that when you just look up an institution's Office of Diversity, you generally do get the impression that that is a priority. I think the websites tend to do their job. But still, I did dig a little bit more and speak to many people at the institution, and I do believe that healthcare in general struggles to aim for excellence, but I think this is an institution that does aim for excellence. And I will say that that perusal changed my title. I often call my talks Beyond Okayness, because I fear that as a standard in healthcare, we aim to be okay rather than outstanding. I suspect that this institution aims to be excellent, and I think part of the wealth is not just what you have in place institutionally, but also that you have an incredibly talented faculty who are committed to this issue and are really moving the science. And I think you may recognize one of the authors on this handful of studies that I've put up. But I think having people on the ground deeply invested is really what makes the difference between an okay institution and one that's aiming for the top. But let's get right down into it, because despite, I think, high engagement on this topic and the increasing awareness and commitment of institutions, as a field, we are not well in terms of safety and equity. And I'll start with this report that came out a year ago from the National Academies of Sciences, Engineering, and Medicine. Can you raise your hand if you're familiar with this report? All right. If you have not spent time with it, I rarely recommend a greater than 300-page report as a riveting read, but I will tell you it is a riveting read. It's freely available for download online, and it was one of those things that I opened it up thinking I would take a look through, and then a couple hours later I closed it. It was fascinating. I will summarize it for you, but I do encourage that you spend a lot of time, because if you care about culture and healthcare, this will disturb you, and I think you will want to change it. The report starts with a very broad definition of sexual harassment, so it includes not just what we think of as kind of overt sexual behaviors, but also a broad definition of gender harassment, which includes all the verbal and nonverbal behaviors that convey hostility, objectification, exclusion, or second-class citizen status. And so taking all these, the full broad definition into account, these are the key findings of the report. First of all, there's little change over time. So we tend to have an optimism that things are just kind of getting better over time as we evolve as humans. And in the case of sexual harassment, from our best measurements and estimates, this problem is not improving over time over the past 30 years or so. Of the sciences, it is worst in medicine, and you can think of why, what the factors in our systems, in the way that we interact with others, may make that so. It is in general overlooked and highly tolerated. We undermeasure it when we do measure it. We poorly measure it without using standardized instruments, although they are readily available. We are stalled on litigation, meaning that when we do address harassment, we try very hard not to get sued, which is a miserably low target for us to aim for. Although there's limited data on women of color, it is clear from what we have measured that they experience more harassment than others. The same goes for sexual and gender minorities, who tend to experience more sexual harassment than others. The sequelae are grave and should bother us. Sexual harassment undermines women's professional educational attainment. There are measurable negative effects on mental and physical health, and it leads to attrition from leadership roles, from institutions, and actually from the field of medicine altogether. Harassment has a stronger relationship with women's well-being than any other job-related stressors. So you think about all the stressors we talk about when we express our concern about well-being in medicine, the volume of patients, the increasing regulatory requirements, the documentation. There's a huge conversation nationally about wellness and healthcare, but we rarely mention harassment in it, although for women this is the largest, most influential thing on their career well-being, and really usurps these other stressors. It's not just about women or other targets of harassment, to be clear, because harassment is like a toxin. The negative effects of harassment extend to the witnesses of harassment, the entire working group in which the harassment occurs, and even entire institutions. So when you hear that this is a problem of women, that women need to worry about, this is not true. It actually is a problem that we all need to worry about because it deeply affects our organizations. The report concludes that the cumulative effect of sexual harassment is significant damage to research integrity and a costly loss of talent in academic sciences and engineering and medicine. They also discuss the organizational antecedents to harassment, which I think is so important. I won't spend a lot of time on it, but I think is, again, worth checking out in its complete form in the report. But I will say that in summary, harassment tends to occur in organizations that are male-dominated and led, that have steep traditional vertical hierarchies like in medicine or the military, and in general a climate that kind of signals that it's tolerant of sexual harassment. So what is that climate? And of course it is not really just about harassment, it is about power and inequity. Let's talk about some of those inequities. Let's start with salary, which is just a very easy one to talk about because it's so quantifiable. This is a study that came out in JAMA Internal Medicine that took advantage of the fact that public institutions have to report salary data. So they took information from, I believe, 24 U.S. public medical schools. And, you'll often hear, well, there's no real salary gap. It's really about this or that. It's about choice of specialty, or it's about productivity. And I will say this study, like many studies that have been published over the past 5 to 7 years, adjusted very thoughtfully for many things. This is a partial list of potential confounders that were corrected for. They include the obvious things like age, years since residency, faculty rank, your choice of specialty, your NIH funding, participation in clinical trials, publication count, and proxies for clinical productivity as well. And with all of that, you can see how you can just see from this how the salaries kind of cluster. So salaries of male physicians are on the left, salaries of female physicians on the right, and you can see for female physicians the salaries tend to cluster at the lower end of the scale. And overall they found that there was about a $20,000 difference in salary that was unexplained. You see the same thing outside of academia. Doximity for 3 years now has done a physician compensation report. They find that in 2018 overall, female physicians earned about $1 for every $1.25 that male physicians earned. And to be clear, as of 2018, at least, there's not a single specialty in which women earn more than men. So another thing that you'll hear often is that we just need to get more women in. Once we get the women in, things will fix themselves. But even in fields that have been dominated by women for a long time, or where there's equitable numbers like OB-GYN, pediatrics, family medicine, the salary inequities persist. And even in nursing, which has been dominated by women forever, and is still 80% women, there's a salary inequity that favors men. So please understand that representation is part of it, but just getting more women in the room somehow still doesn't fix the problem. And we see that most in the highest leadership. This is actually published when the senior author was faculty here at UCSF, and I think the initial study idea was let's see what the discrepancy is between men and women in the highest leadership positions, so looking at chairs of NIH-funded the top NIH-funded medical schools in the country. And then they realized that was probably the findings of that study would be too patently obvious. So they said, let's make it a little bit harder and just take chairs that have mustaches. And they were pretty rigorous about the classification of mustaches, and actually used this as a referent when they went to the websites and documented facial hair on chairs. And they found that women were about 13% of more than 1,000 department leaders in the top NIH-funded U.S. medical schools, while mustache leaders accounted for 19%. And this was in the Christmas BMJ, which, has good science, but is also very funny every year. And so they defined this mustache index, where if you have more women than mustaches, you have a mustache index of greater than 1. And they urged us to, if we can't achieve parity in the highest leadership, then maybe we can at least shoot for a mustache index greater than 1. And of course, you will, you'll see these kind of studies all the time. I think there's a healthcare conference where there were more Michaels as speakers as healthcare executives than women. I talk a lot about kind of these big, broad issues and statistics, but I'll say when I get together with faculty, women faculty in medicine, what we spend more time talking about is really the day-to-day interactions and what we call microaggressions, which I think have a macro effect on people's job satisfaction and their morale and their ability to kind of stay in the game from day to day. And these are so common and so universally relatable for women. Of course, they've developed their own, there's a whole language around them. So if you've heard of me-interrupting or appropriation, you know what I'm talking about. And I think these are kind of like the day-to-day things that are so hard to measure, unlike salary, but really contribute to how well women are able to thrive. So putting this all together, when I was coming up through medical school, I heard a lot about this leaky pipeline and how much of it had to do with women's choices as they move through their careers in medicine. But as I got to know this data, it really occurred to me that when there's a safety gap and there's a pay gap and there's an opportunity gap and there's a respect gap, I don't totally understand what choice there is to be made. You cannot make a clean choice when you're in an environment with these things. And so I say, let's address these things first, and then we will understand a lot more about the kind of choices people make in that in that zone. And the reason this matters to me, I think, was encapsulated so well by Michelle Williams in the Emmys. Did you watch the Emmys at all? It's one of those things that was kind of playing in the background as I was doing other things, and then she said this, and to me it really captured why this matters and what is at stake here. But she said, when you put value into a person, it empowers that person to get in touch with their own inherent value. And then where do they put that value? They put it into their work. Because this is not really about just making women feel great on a day-to-day basis and being fair. It actually is about the work that we do, and because we are in healthcare, it is about what we do for our patients and for the public. And if we can create an environment that is safe and respectful and gives dignity to everybody, that will pay off in dividends to our patients and help us accomplish the goals that seem sometimes so far away. I do want to spend just a short period of time talking about how inequity happens, and I think this data will be familiar to a lot of you, but I think when I leave it out, something feels empty because we wonder, why does this happen? You know, is there malice? Is there bad intent? How does this actually play out? Because almost everybody I meet when we talk about these subjects, they're surprised, and they don't feel that that is something that they would support in their day-to-day working lives, and yet it is so consistent. And that gives you a lot of, cognitive distress. Like, how can this happen? And so I think just going over a couple of examples of how this plays out is really helpful. I do want to say we sometimes oversimplify this problem, and it especially comes to when we talk about implicit bias as if it is the magic bullet. Like, let's just make everybody aware of their implicit bias and the entire problem will go away. And that doesn't really seem to be the case, and I think we really need to acknowledge how inequities are built into the system that we live in. The system wasn't designed with a primary driver being how can we make this really equal for a diverse workplace. And then we still live in that kind of old traditional system and try to make things equitable. I think it's an incredibly complex problem, obviously, otherwise I think we would have tackled it by now. I think there's much that we don't understand or we can't possibly measure or wrap our minds around quite yet. But I do think the bias piece is something for us to be aware of and can actually change the way that we move in our environment every single day. So let's just talk about a couple of seminal studies. This one was out of Yale. Anybody familiar with this study? Yeah, it's a really great and entertaining study to read. So this is a nationwide sample of science professors, biology, chemistry, and physics, about 125 of them. And they were asked to rate an applicant for a laboratory manager position. And they were given one of two resumes, and those resumes were designed to be exactly the same except for one factor, which was the name, which conveyed a gender. Right. And this is how they rated these exactly the same candidates. And so the male student is the dark bar, and the female student is the light bar. And the measurements are for competence, hireability, and mentoring. And then they asked them to take a stab at a salary. And they gave the male applicant. And this is one of those proofiness charts, like the bottom is not zero, just to be clear. But still, you get a sense of that the male applicant consistently would get a higher salary. And to be clear, the bias, the conclusion of the study were that the bias appears pervasive among faculty and is not limited to a certain demographic subgroup. In other words, this was not the female professors doing this, or the male professors doing this, or the older professors doing this, or the harder science professors doing this. Like, all the assumptions we have about who is doing this and who has biases against female candidates were kind of wrong, because everybody was doing this to female candidates in aggregate. There's more than just gender, and I think, as you layer in other factors, it's kind of interesting how we play out, just to make sure. This is just one point to show that this is not to be oversimplified. So it's another seminal study that looked at the specific effect of parenthood. And so in this study, participants read a description of a company that was hiring for a mid-level marketing position. And they, again, examined hypothetical, application materials for two hypothetical applicants. And again, they were designed to be similar in all aspects except for parental status. And the study was so interesting because it gave a very nuanced indicator of parental status. And it was just a line item saying that you participated in the PTA, in a parent-teacher association, which would be really strange if you weren't a parent. And then again, asked the study participants to rate across a number of domains, including competence, commitment, the percent score required on an exam. In other words, how hard are you going to make the threshold for participation? The salary recommended, the proportion recommended for management, likelihood of promotion, their estimate of that, and then who they recommended for hire. And this doesn't compare men versus women, to be clear. This is mothers are in the left-hand column and non-mothers, kind of a horrible term, are in the right column. And so this is how the mothers fared compared to those who were not parents. So I kind of rated them lower on everything, except for the score required on the exam. That went up. So you make the threshold harder so that the mothers can prove their commitment and their competence. All right, what do you think happened to fathers versus non-fathers? So, nothing. What a great guy. He has a family to support, and he's probably even babysitting his kids, you know? And so I just bring that up because I think, as we layer in other factors, we can be conscious of the way that not only do women tend to take a hit, sometimes the differences are exaggerated because there are ways in which when women sink, men actually can rise, which will deepen the divide. So let's bring this to our day-to-day life. I mean, so that's all data and sort of hypothetical things. How does this actually play out in our working lives and in the academic activities that we do? So this was a lovely study out of Mayo Clinic where they took advantage of the fact that their grand rounds were recorded, including the introductions of the speakers. And so they looked, how do the intros differ if there's a woman introducing a woman or a man introducing a woman? They found when a female introduces a female, they use their professional title most of the time, and the same went for if a female introduced a male. If a man introduced a man, they most often use their professional title. However, if a man introduced a female, they use their professional title less than half the time. And so a small thing, but again, when you think about indicators of value and respect, you start to realize how systematically women are undervalued and underrespected. This bias affects our trainees as well, and I won't go deeply into this study. There was also a paired qualitative study. The senior author here is Vinny Aurora out of the University of Chicago, and it is worth spending some time here if you play any role in the education of students or residents. But they looked at 8 training programs. There were over 33,000 direct observation evaluations of residents in 3-year emergency medicine training programs, and found that although the residents by every measure appeared to be about the same in PGY 1 year, by PGY 3 year, they were evaluated lower on all 23 EM subcompetencies, both procedural and non-procedural. So even things that maybe you would think bringing all your expectations about agentic versus communal behaviors, like you might think that women might get purely by chance get rated a little bit higher on things like interpersonal communication or something, but actually quite systematically the women were rated lower. There's a paired qualitative study in which they describe in sum the kind of themes that arose from the written comments in these evaluations, and generally it portrayed a picture of how fine a tightrope we ask our trainees to walk. And so for women, they would 1 month be too assertive and independent, and then the next month they would be too uncertain of themselves. And you could almost picture these trainees being like, oh, I'm too assertive, I'll pull back and bake cookies and ask more questions, and then they were too passive and weak and ineffective and they would overcompensate. It was like the same resident going through time got this kind of, crazy back and forth. I probably shouldn't say crazy too loosely in this room of psychiatrists, but really got a very difficult range of feedback around their behaviors. Whereas the male residents got very consistent feedback that they could not be assertive enough, that even aggressive behaviors seemed to be rewarded and rated highly. So I think one thing, a lot of these problems are kind of big and systemic. It's very hard to change them. One thing you can change today if you interact with trainees is to be very conscious about the kind of feedback and evaluations that you give residents, and be aware of how you might bring your own biases into it. Another example, and this one is actually from somebody at UCSF, Michelle Lin, who is in emergency medicine, a very well-known educator nationally, and she started this website called Academic Life in Emergency Medicine, which is hugely popular for students and junior trainees who kind of want tips and advice from more senior people in emergency medicine. So Michelle started this series called How I Work Smarter, where she asked faculty to talk about both clinically and in their academic life how they were efficient, how they got things done. And she tapped 4 friends, I was one of them, and asked us to sort of take a picture of our workspace and answer some questions. It was super fun. And the way that the series ends for every person is you have to tap 3 other people to participate in this. And so this is what happened. She picked 2 women and 2 men to seed the series. Each of the men picked 3 other men. The women picked 1 or 2 other men, and then every subsequent iteration of this, the men all picked other men, and the women picked a mixed group. So you can imagine what happened 3 or 4 or 5 generations into this series, right? And we didn't even notice. We were having so much fun with it. This is great. It's taking off. And then finally somebody on social media says, what is up with How I Work Smarter? Why is it all men? Do women not work smarter? And we tore through all the participants to see what had happened, and we realized what had happened. And then we confronted the men and said, what is up? How did you all pick 3 other men? And what do you think they said? It's a great discussion that played out on social media. Did they say it was done out of malice to reinforce the patriarchy? Did they say, we believe firmly that women do not work smarter? That is why they could not be recommended for this series. No, they were mortified. I mean, every man, down to the last man said, I easily could have named a dozen women for this series, but I was sitting there with my buddies at this planning thing, and I just said, dude, I'm tapping you for this thing. And then the conversation became, how were all of you just sitting around with a bunch of men at the table for all your planning committees, doing academic work, writing papers? Interesting. And it actually led to a wonderful discussion, and we were able to go back and reseed How I Work Smarter with a more intentional approach, and it became more equitable very quickly. But it was such a lesson to me on how these things are born not out of malice, but just out of habit and circumstance and ease and bias, frankly. And that's how you get things like this. Yes, Manels. So you guys are familiar with the Manels? So the Manels, all men panels, are so prevalent that they have their own Tumblr. So this Tumblr is called Congrats, You Have an All-Male Panel. And the face of it is David Hasselhoff, which is inexplicable and perfect all at the same time. And so, it's this website where people submit examples of all-male panels, and they're stunningly common, and you just got to wonder what is happening there. But we see this all the time in academia, and the real problem is, it is kind of funny, but it also is, these are the things that lead to recognition and advancement and promotion in academia, so it becomes not funny. And this really, really penetrates everything that we do in academia. So this is a study out of Brazil where they have a national data set. If you get federal funding, you put all your productivity there. It's kind of similar to what we have, but they capture gender in there for whatever reason. And so these researchers looked across fields, so not just in the sciences, but looked across fields and looked at when there was a female PI versus a male PI, what was the composition, the gender composition of their teams? And we often say, well, there just aren't women in this field. We really try to include women to the proportion that they're available. So in this group, they use that little yellow triangle, and that is the number of women available in the field who published and is in this database. And then the red bar is the proportion of women that women PIs worked with. And then the blue bar is the proportion of women that male PIs worked with. And so you can see, in general, male PIs worked much less often with women in much lower proportion than how available the women were in their fields. And I thought the title, Women Are More Egalitarian Than Men, was a very friendly one, if you kind of think about the way that you could name this. But I think in general, again, if there's something that we can change today, this week, this month, this year, it's to really look at the composition of the teams that you put together. Because, again, these teams, that is how we do productivity in medicine, and that is what goes into grants and funding and every measure that we have for advancement. And if those aren't fair, then none of the rest of it, not the money, not the leadership, not the power, will be none of those can be equal either. Make sense? All right. So let's move on to solutions. I kind of tore through that beginning piece to make sure that we had time for this part, because I think this is where we want to be. It's really thinking about solutions that we can, solutions and approaches that we can implement. And I think the first place is to really understand the impetus for fixing it, because it's not about fairness. I rarely use that word except to say that I'm not going to use that word, because I think there is actually much more compelling reasons to shoot for equity and safety. One is a financial reason, actually. McKinsey has done really incredible work looking at what happens to companies in terms of their bottom line, in terms of their financial returns and their customer base, if you increase diversity in the workforce and in highest leadership. This goes for both gender and racial and ethnic diversity. And what they find is that if you're in the top quartile of gender diversity, your financial returns are consistently about 15% higher than those in the lowest quartile. Very similar findings, but more so for racial and ethnic diversity. And when you look at everything that defines a successful company, diversity in both gender and racial and ethnic composition is a strength, is a win for that company in terms of the talent that you're able to recruit, how your connections are with your customer base, your employee satisfaction, the quality of your decision making, and also your company's image in the public. All things that every company wants, right? I think for us in healthcare, too, we need to think about the clinical case for diversity of all kinds. Are any of you familiar with this JM Internal Medicine study? Probably one of the most controversial and most read studies that they have ever published. This was a study of Medicare patients who were admitted to the hospital, and they took advantage of the fact, it was a national sample, and they took advantage of the fact that when you get admitted to the hospital as a medical patient, it's kind of like a quasi-randomized study, right? You don't walk in and say, I would like the male hospitalist who's on today. You just get who's ever on. So looking at that, they looked at a wide range of cardiac morbidities and of mortality and 30-day bounce backs, and found that overall, over millions of data points, patients treated by female physicians had lower odds of death and readmission compared with patients cared for by male physicians. And there were a lot of really thoughtful sub-analyses represented here. So recognizing that men are more likely to be intensive care unit doctors, they did sub-analyses that took those patients out because they're sicker and have higher risk for morbidity and mortality. And the findings were very consistent. Most of the studies that look at things like gender or racial concordance or just diversity when it comes to patient care measure things like patient satisfaction. Did you feel listened to? Did you feel a connection with your doctor? Did you trust them? This study was really like, just straight up, did you die? Which is, I think kind of where we need to go in terms of really establishing the value of female physicians. And what this study said to me more than anything is that is in question. that is actually a research question. So it was both a great study to read, but one that saddened me deeply. Another study that I love from my own specialty, this was looking at gender concordance when people come into the emergency department for heart attacks. And another large cohort of patients across from claims data across Florida hospitals. And they looked at what happened if you're a female patient, you come in and you receive either a male or a female treating physician, so emergency medicine physician, not the cardiologist, but the receiving physician. And they found that if you were a woman and received a treatment by a female physician, your odds of survival were markedly higher. And then they did something really interesting, which is they looked at the outcomes of patients who were simply treated in departments that had a higher proportion of women. And what they found was that if you're a female physician and you came into an ED where there were more women in general, your odds of survival were higher, even if you had a male physician. And particularly if you had a male physician. So the performance of male physicians improved markedly if they had more female colleagues. And I think that actually is a much better study than the other one I talked about, because it's not about, it's not just about who does better. Do women do better? Do male do better? Do men do better? I think it's actually really, truly about diversity. When you have a more diverse team, the collective intelligence rises. We know this from many, many studies, and everybody is able to do better in that. And I think that is really the answer to concerns about the zero-sum game. When women rise, somebody else has to go down. When this group rises, this group has to go down. This is actually about all of us rising together, because our more diverse team and leadership team will do better and will help us get to where we want to go in healthcare. Do you buy that? That's the case we need to make. Another part of the solution, I think, is really approaching this just in the same way that we approach other challenging problems in medicine, and we do it very methodically. We have entire frameworks that we use. One very common one is the Donabedian framework, which is what we use to assess the safety and quality of our healthcare initiatives. And so when we want to bring something to a healthcare center, let's say we want to build a stroke center of excellence, we think about the structures in place. In other words, what are the resources, the policies, the procedures, the human resources, the physical resources that we need in order to create this program. And then we look at the processes. Are we actually following through with our policies and procedures? If not, then why? We have a million intermediate measures for whether we're implementing this planned program effectively. And then we obsessively measure outcomes. We follow stroke patients from before they get to the hospital to really long-term 30-day, 90-day outcomes. And all of that information constantly gets kicked back to us. So if I get a potential stroke patient to the CT 30 seconds too late, I receive an email about it within weeks. My email is full of nastygrams about stroke metrics that I did not meet, because we have a very tight process when it comes to assessing the quality of our stroke center of excellence. We could really do this for everything that we care about in the realm of safety, equity, and diversity. So you can imagine being very comprehensive about the structures that we have in place. Are they adequate for our needs, and are our needs defined by things that we care about? What are the processes we have in place? Every organization I go to can brag about their policies and procedures and plans. Very few can tell me about how they know, about what they know about how well those policies are being implemented and if they're being done in a timely and satisfactory fashion. And then outcomes are where we really fall out, which is kind of surprising and disappointing when you think about how we are so outcome-driven across every domain in healthcare. And then it comes to issues like safety, equity, and diversity, and we have a hard time articulating what our goals are. What do we accomplish in healthcare when we can't articulate our goals? This is something that a clear area of needed improvement for us. And again, the same thing with recruitment, hiring, retention of a diverse workforce. Do we have the structures in place to support this? What are our process measures? What are our clear, articulated target outcomes? And how are we improving every year to make sure that we're making progress towards those outcomes? So I think overall, this process, whether it's called Donabedian or something else, just making sure that we have adequate resources, that we are executing our plan well, and that we are measuring and measuring and measuring our well-articulated outcomes. The nice thing about this is that this is what we do every single day in healthcare to ensure quality and safety of our healthcare delivery. So I know that we know how to do this. We just have to do it. All right. I think another critical part of success in these areas, of excellence in these areas, is to talk about these issues a lot more than we generally do. I mean, obviously we're talking about it today. I was invited here to talk about it. But what about when we go back to our regular days? I want to acknowledge that there are real challenges and barriers when it comes to talking about both equity and safety, and really everything that I've talked about today. And those concerns and those barriers are real. It is hard to talk about this. Often in departments that I go to, there's that one person who loves to talk about it, and everybody else kind of rolls their eyes when that person opens their mouth. I am that person in my department. I can guess who it might be, or sometimes there's two or three, and I guess I can't overemphasize how much it is hard to be that person. It's hard to be effective at that person, and really what needs to happen is that we all need to take part in talking about it. And I think there are ways that organizations can make this easier for us to talk about. I think we should routinize conversations and open problem solving around bias, inequity, harassment, micro and macroaggressions. We need to create regular and structured opportunities for discussion, and we need to approach this like any other topic in medicine. And I think a great example for this is how hard it was a generation ago to talk about errors in medicine. I was still, when I started medical school, M&Ms were terrifying things, and it was not unusual for someone to cry during them because the approach was, what did this person do that was so horrible? We do that for sexual harassment too, and for discrimination. We try to find a scapegoat. And so when you look at news stories about harassment, there was this awful person who did awful things, and thank God we got rid of them. That's actually not right? Because the real question is, if we think about how we do M&M or CQI, we talk about what are the organizational factors, what are the holes in the Swiss cheese that allowed this case, these errors to happen, and what we really should talk about in cases of harassment, discrimination are, what was the system that allowed this person to thrive? How was that harassment even able to happen? And how can we change the entire organization, all of our behaviors, so that does not ever happen again? And I know from my extensive web surfing that this is something that is happening at UCSF. I saw your climate and culture assessment. I saw findings related to strengths. I saw very frank opportunities for improvement. So I really love what is happening here, and I think the only part of the recommendation is just yes and more. I also saw your salary equity efforts and how there was a very large effort in 2015 to correct existing inequities. And I think that is a wonderful move and an excellent place to start. When I do these kind of big picture talks, I often get people saying, but what can I do today? Because I would like to be part of the solution while we're waiting for the entire organization and entire field to change. And I think there are so many things, some which I've already alluded to, that you can do just in your day-to-day interactions. And I will say, for everything that I've talked about, all the studies that I brought up, each one of them sparked in me a desire to do better at the gate that I manage, even though my gate has always been very small. I don't run big healthcare organizations. I don't have a major leadership position in my department, but I realize that almost every single day there's something that I can consciously do to try to make sure everything is managed well at my gate. And I think if we all did that, if we all took responsibility for what was happening at our gate, and I hope that any of you who are trainees in the audience and go, to many places across the country, I hope that you take the concept of just managing your gate well there, because I think that alone can make a difference while we're working on some of these bigger issues. But just think as you go through, even just today, your day-to-day interactions, who's speaking at the table, what language is used to discuss and address people, to recommend them? What are our immediate gut level assessments of competency and value? What are our assumptions about people's commitment and availability? How do we confer roles and responsibilities? To whom do we give opportunities, both large and small? What is the diversity of your scholarly teams? This is one thing everybody can leave the room. Pull up your projects and look at your authorship teams. And if they are not where you want to be, change them today with a few emails of outreach to people that you might not ordinarily include but might bring tremendous value to that activity. Consider if you're part of any committee that brings in speakers to grand rounds or to a conference, consider the representation of speakers and representation very broadly. I mentioned gender a lot, race, ethnicity. Think about many other types of representation. Think about sexual orientation, gender identity, diversity and ability, and all the things that we rarely consider in diversity. And then also consider who is recognized and rewarded, because if you look at any awards program, often they're lacking in broad representation. I think change is coming. It is very encouraging to me. The AMA in the past year adopted a resolution to advance gender equity in medicine. They are also considering a resolution to formally partner with Times Up Healthcare to advance safety, equity, and dignity across healthcare. And I think more than anything you see, more than any other time that I've seen, there are major organizations getting behind the issues of advancement of women, safety, and equity. And that, of course, includes Times Up Healthcare. Christina Mangorian and I are both founding members of Times Up Healthcare. We're working on a national level to try to raise the bar for safety and equity for all workers in healthcare in every role and in every setting across the country. I welcome any questions about Times Up Healthcare. I hope you check out our website and sign up. I also have 3 pins for the first 3 people who asked me for them. And I really welcome all of your efforts in this work, whether it's at your gate or on a larger level across your institution or in national organizations. I appreciate your time, and I did want to leave some time for questions and discussion.
That was outstanding. I've got a microphone, so I'll go up. I see a question over there.
Thank you, Dr. Chiu, for this wonderful talk. I really love it's very clear to hear the data and be very concerned, and I appreciate that. The thing I wanted to ask was whether there was anything you could say about the contribution or impact of organized labor on this problem. I ask that because here at UCSF, the residents and fellows are organized under Committee of Interns and Residents. It's the largest physicians union in the United States, and it was through that we were able to extend parental leave to double its prior length. And unionization does offer people concrete protections from retaliation and abuse at work, and they're conspicuously absent for the most part in the United States. So I was wondering if there's anything that you could say about the data on that or other comments.
Yeah, totally. In Times Up Healthcare, we think about how, with an entrenched problem like safety and equity in healthcare, we need to approach every single pillar that holds up the existing structure and prevents us from making progress. So when I think about those pillars, it's really, it's everybody. It's employers, it's regulatory bodies and accrediting bodies, it's funders of our science that really hold up our institution, and it includes unions. And so for Times Up Healthcare, one of our major and our very first partner is with the SEIU, because they're one of the most like-minded organizations in terms of constantly thinking about safety and equity. I mean, it really is like the principle of a union, is to be able to negotiate for those things. And we're doing a lot with SEIU that will roll out over the next year. Things like most SEIU chapters have a budget specifically for boosting safety of its workers. I spend most of my time in physician spaces, but honestly, the greatest urgency for us right now is improving the safety of the in-the-field workers. So if you have not sat down with a home healthcare worker and asked them to tell you a few stories, please do that. They are, they'll like kind of raise the goosebumps on your flesh. What they go into every day in isolated circumstances without the safety of a community is really shocking, and some of our efforts will be to improve everything, the resources they have, what they're able to negotiate in their contracts, and standards for employers who are really the patient and their family, so that we can affect change across actually wide swaths of the country in terms of impact. So yes, I think unions are critical to this conversation. They actually have many innovations that we haven't brought into an organization otherwise, and they're an incredibly important lever. So I see them as a partner in this work.
Hi, I'm Elizabeth Ozer, faculty here at UCSF, and thank you so much for that. And I really appreciate the way you also really brought it home for us in terms of the day-to-day. I just have one comment to make when you talk about the collaboration and your scholarly team, which is so great to be always thinking about. There's also data that you probably know to suggest that actually when women get evaluated and faculty get evaluated when they're part of collaborative teams, there's an assumption that they may have contributed less than the men unless that is really distinctly pointed out. So it sort of goes to say at every one of these levels how we need to think structurally about the next step and how all these things get interpreted. But generally just really appreciate both the broad stroke and the nuance. Thank you.
Thank you, and I completely agree with that comment.
Hi, my name is Christine. I'm actually a radiologist. Thank you for the beautifully eloquent explanation of the factors behind it. I have two questions. One, I would love a Time's Up badge.
You got one.
And second, I'm very interested to know about your experience on social media. You have a very big place on social media. I imagine that comes with positives and negatives, but how do you think that has changed getting the message across to the community? I have my own personal feelings about some of that, but I just wonder how it's been for you.
I'm sorry, I'm hesitating because where do I begin? Social media is a big part of my advocacy, and, I could complain about sort of trolls and the way that people pick apart things, but at the same time, the reason I have a Lancet column is because I met the editors of the Lancet on social media, and there were a lot of similar issues that we wanted to talk about and encourage discussion of. So it really, I think it really is part of this emergence of means by which women can network and mobilize around some of these issues of equity and harassment. And I really feel this past couple of years has felt unprecedented in terms of how much we can gather online and in person. There are more women-focused conferences in the month of September this year than there ever were. There would be over the course of the year, 15 or 20 years ago. Dangerous things happen when people gather. And I think what's wonderful is that we can gather in our living rooms, in off hours. And I think it plays a vital role in terms of even something as little as, a cycle ago, if something happened in a meeting and I thought it was a microaggression, I would think about it, I would have nobody to really talk about it to, and I would decide it was my fault. There was a lot of internal attribution. And I think because of social media and that platform and its availability, we're able to find, sorry, that was me reminding myself to stop talking. I think the way that we are able to find genuine attributions that are outside of ourselves is kind of a lifesaver, and allows us to have much more productive conversations about our immediate environments and about sort of structures across healthcare. So it's to me, has been obviously very professionally rewarding, but I actually think for this movement, the things that we want to do, much of it is happening on social media. Ideas are generated there, coalitions are formed, real productivity is happening. It's fascinating. I am there every day wondering, what the heck am I doing here, even 6 years in. Because it's a little bit different every month. But I think it's interesting how it is now possible to tell in a brief conversation who is on social media and who isn't. We develop language there. We share concepts there. And when I talk to someone who has never heard these things, it is obviously they're not part of Med Twitter. That makes me a little bit sad. But I think in this day and age, it is so important to be there, to be clueful about these kinds of conversations. So I could say much more, but I'll stop there.
Thank you so much for your talk. It was incredible. I really admire all of your work. I'm Joanna. I'm a postdoc here in psychiatry, and I am curious about within the sexual harassment sphere and Title IX and the way that universities tend to handle these types of complaints, your thoughts on how we shift the fear of litigation to not be the priority, and the role that funding agencies like the NIH might play in terms of shifting the incentive structure around making some of these changes, like taking indirects away when universities are not kind of complying with policies.
Yeah, I mean, obviously, I'm really thrilled that NIH is stepping into this. They've been a little slow, particularly vis-a-vis NSF and other funders. I think they're early in their process. I know that they're early in their process and really struggling about how to be effective, but they're in it. And they're in it as a holistic issue. It was no coincidence that Francis Collins came out against Manels in the same year that they've developed, a task force to advise the director on how to be proactive around sexual harassment. All of these, all these approaches are so downstream. And if you look at the NIH, their working group that advises the director, what their first year preliminary recommendations were, they were to take action when institutions found evidence of fault. But we know that even complaints to institutions, formal complaints, are just the teeny tiny tip of a very large iceberg, because there's so much, there's so much between a person and just reporting. Because of the vertical structures and things like that. And so I guess, I think we have a long way to go. Time's Up is trying to we're having, starting the process of having sort of convenings and webinars where we talk about legislation that is coming. So rather than sort of being like, we're meeting legislation that's already in existence for years, let's anticipate legislation that is coming. Not all of it will actually come through the Senate and actually become law, federal law, or and not all of it will actually be felt on the state level. And yet, if we know what's coming, then we can sort of start putting things in place ahead of the law. So we think about changing laws, but we actually think about changing employment, and so that employers start talking about being way ahead of the law, and sort of, we talk about sort of bringing up the floor and also raising the ceiling. So getting people to do more than the bare minimum and just skirt by, but also raising the high standard, what we're shooting for. And so I think just persistent conversations about here's the law, and here's a layer better, and here's a layer better. I just put in my first grant addressing sexual harassment in academic institutions. It will not get funded, but it was really fun to think about, and part of the grant was actually bringing in co-investigators who have a legal background in this area, and for every type of policy and procedure to say whether it met legal requirements or exceeded them, so that we have actually like a clear sense of here's where you go if you are actually an institution aiming for excellence and not just for the bare minimum. And I thought that categorization might be helpful for organizations that want to be more assertive and proactive. But right now I see it as, for the most part in the realm of harassment, we are only aiming to detect widely metastatic disease. We are not doing preclinical screening at all. And I really want to see us move to preclinical, or at least early clinical stages in terms of sexual harassment, so we can nip it in the bud, and then the next generation can really work on prevention. Thanks for that question.
Well, this is, as I told you, this has been incredible. So thank you so much.
Thank you all for your time.
Thank you, everybody.